So health services across Manitoba are provided in facilities on the original lands of First Nations and Inuit peoples and on the homeland of the Métis Nation. Manitoba health authorities respect that First Nations treaties were made on these territories, acknowledge harms and mistakes, and we dedicate ourselves to collaborate in partnership with First Nations, Inuit, and Métis peoples in the spirit of reconciliation.
Hi, everybody. My name is Joel Yannick. I'm training officer in Brandon with Brandon Fire and Emergency Services, and I'm joined by Lindsay and Kat today. We're going to start off just by letting them introduce themselves, and we're going to try something a little bit different. If you're following along with us and watching the video, that's great, but hopefully we're going to set this up in a way that you can just listen to the audio file. So if you have this playing in the background while you're driving, hopefully you still can take something away from it and gain some knowledge about ketamine. So, Kat, do you want to introduce yourself?
Yeah, hey everyone. My name is Katrina Cornwall. I'm one of the educators in West Zone. I've been in ICP for close to 14 years now, and I'm super excited to talk about and bring back ketamine. It's a drug that's been used for us in the past, so we're going to try to reintroduce it to you guys.
Awesome. And Lindsay?
Awesome. So thank you very much, Joel. My name is Lindsay Dudich. I'm one of the education officers here in West Zone as well, too. I am based here in Dauphin. I've been a paramedic going on 10 years. I've been in ICP for about 6, 7 of them. I am a licensed ACP. Been in education for going on about 4 years already, and I am super excited to bring back ketamine here. We've had tons of successes when we had it around this last time, so hopefully we can pull some more education for you guys and get you a little bit more confident for this next roll around here.
Yeah, totally. So for anyone that's been in West Zone or around the province or in Brandon, we had ketamine. Obviously, due to the shortage, it got kind of pulled from our scope, and we're getting it back in as stocks are kind of replenished now. And we just want to make sure everyone's really comfortable with it. Ketamine tends to have a bit of unknown to it, so hopefully we can kind of calm some of those fears. So Lindsay, do you want to tell us a little bit about how ketamine works?
Yes. So pharmacologically, it's actually categorized as a general anesthetic. However, the cool thing about it is it actually has a really, really wide range of dosing, and depending on the dose you give, you can get different effects. So when we have like the really, really high doses, that's when you're going to get your general anesthetic dose. But the range that we're working in, it's actually the lower end of the dose. So that's where we can actually get our pain management effects with this. So it actually works on the NMDA. It's an antagonist, so meaning it actually stops the excitatory neurotransmitter glutamate from exerting its effects. This is what it's thought to actually give ketamine the properties of like having that kind of like amnesia or like that psychedelic effect. What gives ketamine its analgesic effects is that it actually interferes with the signals coming from the brain right from that spinal cord, and it actually depresses the emotional response that comes with pain, meaning it actually doesn't allow the brain to associate with pain at all. How or I guess why it's actually different than our opiates is when we give fentanyl and morphine, it's almost like we kind of trick the body into not feeling pain, whereas ketamine, it completely dissociates or disconnects you from the pain you're actually feeling. So it stops the pain in a different kind of way.
So for these types of patients, we're going to be using them. PCPs and ICPs it's come back for. So I'll start off with our PCPs. What they're going to be using it for intranasally is short-term analgesia for extrication when vascular access can't be obtained. So it's really great to have that option for our PCPs. And for our ICPs, it's coming back. And in this time around, it's being used very firmly as a secondary medication when other analgesics alone is not effective, or this time around it's going to be used as an alternative to the other agents like opioids or ketorolac that we have. So when we think about some alternative situations for the use of ketamine, we have to be using our clinical judgment when we're thinking about these types of patients. And that starts with having that informed consent of the medication and having that discussion with our patients, letting them know what we recommend they have, how it's going to make them feel. And that might lead us down the road of some patients maybe not wanting ketamine, or maybe they have a history of opioid abuse and they would like to refrain from our opioids. So there's definitely some situations, and of course, when other analgesics are contraindicated. One that kind of comes to mind would be in the case of a head injury. Our opioids are not indicated for that type of injury. So we can think about ketamine in our head injured patients who do not have a depression of the CNS, which is kind of cool. We do have an option for these patients.
Yeah, and
Absolutely.
I think just to kind of touch on something you said there, Kat, I think it's really important for us as healthcare providers to really give people the choice of the treatments that they want. And some people might be a little bit nervous about receiving ketamine as a treatment. And that's where our job is to kind of let them know what's going to happen, or maybe calm some of those fears for them, and ultimately respect their wishes if they choose not to want ketamine.
Mhm.
Yeah, absolutely. And you can easily slide that into a conversation that you're having with your patient, and remembering to use those layman's terms when you're describing how a drug works.
Yeah, totally. Cool. So I think for anyone that's heard or done anything with ketamine, or heard about it, done any research about it, you're going to find that ketamine's getting used for a lot of different situations. And there's kind of different dose ranges that we already touched on. So there's a lot of research out there saying that people are having success treating pain anywhere from that 0.15 to 5 milligrams, and that 0.15 to 0.5 milligrams, which is our dosing, is that 0.5 milligrams per kilogram. And we can give that IV or IM. If we get into that 0.5 to 1 milligram per kilogram, we're kind of entering into that recreational zone, which will get a few different reactions. And then it's being used quite frequently for procedural sedation, for things like intubation. And then in a lot of agencies, you're going to see it being used as a chemical restraint for agitated delirium specifically. And you're looking at like 3 to 4 milligrams per kilogram. Sometimes IV, you're probably thinking more IM, as that's like a patient that's being held down and that needs to get in pretty quick. But we're not going to be using it for anything other than analgesia. And interestingly enough, ketamine's being used as a psychotherapy treatment for a lot of first responders specifically, as it does lead to sometimes that out of body kind of third person perspective of your own experience. And people are having a lot of success with that. So obviously that's not something we're using it for. We're going to be using it for pain management only, or the PCPs are using it for prolonged extrication where we can't get IV access. So we can give an IN dose. We'll get into that a little bit more as we go, but we just wanted to point out there's a ton of different uses for this medication. As providers in Manitoba, ICPs are using it for IV or IM analgesia, and then PCPs can use it for prolonged extrication when you can't get that IV. You guys have anything you want to add in there?
No, honestly, you just kind of hammered everything. Absolutely. I appreciate that you explained that kind of sliding scale of the dosing, because it kind of puts it into perspective of the dose, and the weight-based doses that we're giving, again, is really on that low end. So, yes, we are going to be producing that pain management effect, but again, it's really the low end of the dosing possibilities with ketamine.
Awesome.
Yeah, and so going back to that slide, Joel, I just did want to point out that the dosing for the IN is a little bit higher, and it's 0.5 to 1 milligrams per kilogram, and that's because of the bioavailability in the nares. Um, it's not going to get absorbed as predictable as something like an IV medication would. So that's why we have to dose that higher. So it might look like we're creeping into that recreational dose a little bit, but in hindsight, it's just because of the route that we're administering the drug.
Right. In reality, the dose they're going to absorb is actually smaller than our IV dose.
Yeah,
For the
you hit that on the
ICPs.
head. Yeah.
Cool.
Yeah, exactly.
All right. Let's move on. And why don't we talk about a little bit about what we can expect when we're giving this to our patients? Kat, do you want to
Yeah, and
give
the
us your
interesting
perspective?
thing, yeah, the interesting thing about ketamine is because of the way it works, we get a variety of different effects at different doses, just like our chart there showed you guys. Um, we're going to achieve that anesthesia and sedation at those higher amounts, like we talked about. But some of the adverse effects that we might be seeing as well do come into play when we're talking about this type of medication. Some of the adverse effects for anesthesia and sedation, we risk CNS and respiratory depression. So, really, our basic management for these patients, our ABCs, right? That's what it always goes back to is our BVM, our iGel, OPA, suction, oxygenation, all of our basic things. There's always a risk with any of the drugs that we do administer that we can cause any of these CNS, respiratory depression. And I like to think of it as, when we give fentanyl, we know the risk where we might cause respiratory depression and we know how we're going to manage that. And the same goes for ketamine. We do run those risks. They might be lower, but just understanding how we can manage them. And I know Lindsay could talk a little bit more about some of the more adverse effects that could happen with the administration of ketamine. Not always, but just things that we need to be cognizant of.
Yeah, absolutely. Like exactly what Kat said. Anything that we do on truck, we always kind of almost have to have that backup plan, right? And when we are prepared with those backup plans, that's where we can start building our confidence and really, really quick treatments when it comes to potentially seeing those adverse effects. So exactly what Kat said. When we're giving fentanyl or morphine or even midaz or something in certain situations, yes, have everything ready just in case those adverse effects actually take place, because then you can quickly start treating those adverse effects. So again, same with ketamine. Again, it's a very, very low risk that we're going to see those, but again, it's not a bad thing to be prepared. Okay. So when we start talking about some adverse reactions to ketamine, again, it's really just going to be patient dependent. So one of the big first ones that we do want to talk about is our emergent or our emergence reaction. Sorry, I had to spell that one out there for myself. So when we talk about that reaction, by definition, it's the undesirable effects and unpredictable occurrence that can manifest with the administration of ketamine. This can occur with the dosing range that we do administer, and it can happen to really any of our patients. So when we talk about this, it's presented kind of like our typical bad trip with dissociation from reality. Our patients could be experiencing like vivid dreams, they could have anxiety, agitation, complete image distortion. And honestly, when you're in a crisis, that's a very, very scary thing, right? So again, this is kind of one of those where we give the ketamine and our patients are just not present in reality right now. And there is always going to be the potential that, you know what, we might actually have to pull out some midazolam and potentially administer some just to chemically restrain them so we can actually control them. Again, it's going to be based on the indication to use the midaz in that situation. But again, it's one of those things just to be aware of. Another thing that we can see is, again, that amnesia. Because of how it works on the NMDA receptors, we could potentially see memory loss. And again, it's not the worst thing, but again, it's something that we need to be aware of, because again, it's with that communication that we need to have with our patients when it comes to treating them, right? We can actually see respiratory arrest or depression. Again, very, very low chance with the dosage that we're giving, but that is something we need to be prepared for. That risk can also be potentiated when it's co-administered with opioids as well too. So they basically kind of work synergistically. So again, if you're giving some opiates, that's absolutely fine. If you want to follow it up with some ketamine because maybe those opiates aren't working, again, absolutely fine. But just know that we could end up causing some of that depression just because they're going to be working together. Okay. Cardiovascular effects. There's always some consideration for those. We can see some dysrhythmias because it actually blocks the sodium and potassium channels. We might notice some hypotension as well too. Um, Again, you can see it go down a little bit more, so you might actually see their blood pressure go up a tiny little bit and their heart rate go up a tiny bit. But again, hypotension is always one of those risks that we can see. It could also worsen ischemia by increasing myocardial demand itself. So that's why we do not want to use ketamine in an ACS situation. So if somebody's actually complaining of chest pain, no, we're not going to be giving ketamine because, again, it can actually make that worse. We could actually see some laryngospasm as well too. As per up to date, their larynx could actually spasm and actually close. Again, small population, but it's something just to be aware of to continuously assess and have your airway adjuncts ready to deal with that. Okay.
And again, I think with that, Lindsay, with the doses we're giving, and as long as we're giving it slow, the chance of seeing that laryngospasm reaction is pretty low.
Exactly.
Very low. So yeah. So we've got all those potentially adverse reactions. Do you guys want to talk a little bit about how we can set our patients up and ourselves up to just have a successful treatment?
Yeah, absolutely. And we're giving this information so you guys are aware and you have that understanding of the adverse effects of these drugs. It doesn't always mean they're going to happen. And you
No,
are
no, no.
totally armed, with all of the arsenals in your toolbox to be able to manage these patients. So how we can pass some tips along to mitigate the risks that are associated with ketamine is remembering that it is a slow push, and the care map reflects that. We want to give it low and slow. And another way we can mitigate the risks too is what we're doing today is understanding the effects of the drugs that we are administering so that we can be prepared to have to be able to intervene with these patients to have a successful administration. And that includes making our patients feel safe, right? Explaining the medications to them, letting them know they may experience an out of body experience, and that is expected. It can be quite calming. Having them set themselves up to think about maybe a perfect vacation, a relaxing and peaceful place, make sure the lights are turned down low. You talk in a soft tone. Really reducing that stimulation is going to go very far when you are preparing to give this medication. You're doing your patient and yourself a really big favor. I don't know, Joel, do you have anything more that you can add to be
Yeah,
successful?
maybe the one thing I'll add to that is we don't know what kind of a, for lack of a better term, trip they're going to take. And like you said, kind of set them up for just take them to their happy place. So get them to think about whether they like the mountains or the beach on the mountains. That's maybe where they'll go. But avoid things like, I don't know what's going to happen, because you're planting that seed of doubt. And then if they do start having kind of a wild trip, kind of like the Medusa picture we have here, it's going to be real to them. And don't try to tell them it's not. Just say, kind of reassure them, let them know that they're safe and that you believe them, that they're seeing these things. And just
Validation.
yes, exactly. Just be on their team. That's all anyone ever wants. They want someone on their team. And I think so often we overlook that as providers, that we just have to be on their team. So yeah. Are we good there, Lindsay or Kat? Go ahead, Kat,
Yeah,
sorry.
I mean, unless Lindsay has something more to add, I think, you really hit the nail on the head there with everything. And setting ourselves up for success and, putting on the cardiac monitor, making sure our end tidal is on. These are not only going to be monitoring our patients, but they're going to set us up for success so we can see subtle changes very quickly if they are going to manifest.
Yeah, totally. And we had talked about this before off the call, but putting the end tidal CO2 on it's the low hanging fruit, that we can throw that nasal cannula on. We can put it on before we started our treatment, And even if you're not great at reading end tidal CO2, we can all read their rest rate, and it gives us immediate feedback of their rest rate. So if we're giving our opiates, throw it on. If you're giving your benzos, throw it on. If you're giving ketamine, just throw it on. And the more we get used to just putting that end tidal CO2 on, the more comfortable we get with it. And we get that immediate feedback. And Lindsay touched on before that we have midazolam in our arsenal that we can add midazolam in. We also have lorazepam. So if it's, you can see it's not going in the direction we want it to be, or for them, we want them going, we can get them to take that sublingual lorazepam, as we have that available too.
Mm-hmm.
And then do either one of you guys want to just talk about any interactions with how this might work with someone who's a regular cannabis user or some mental health illnesses?
Yes, absolutely. So cannabis psychosis is a situation that could actually occur, although it be it rare. Again, it's one of those things we just want to make you guys aware of, so that if something was to happen, you could be like, okay, yes, Lindsay, Kat, and Joel actually told me about this. I know how to be prepared. Okay. So this can occur in chronic users of cannabis, especially when large amounts are taken on a regular basis. So when ketamine is actually administered, there is the possibility that because of that large amount of cannabis that's used on a regular basis, it could actually induce a psychosis-like state. Again, not a common effect, but it is something, again, just to be aware of. With that being said, cannabis use is not contraindicated for the use of ketamine. So again, something to be aware of, but nothing to be scared of. Because you know what? We're awesome paramedics. We're super smart. We know how to set ourselves up for success, and we're going to do our due diligence to make sure that our patients are like, "Okay, yes, let's do this. We got it." Right? Perfect. Another thing that we do want you guys to be aware of is anybody who's diagnosed with schizophrenia. They can also experience a psychosis-like state if they are administered ketamine. Again, it's not contraindicated for these clients that we're going to be seeing. It's just something to be aware of. If they are in a having an episode with their schizophrenia and we were to give some ketamine, sometimes that ketamine can absolutely potentiate a psychosis-like state. So again, it's not contraindicated, but it's something that we can try talking with our patients. Maybe we'll have some of that lorazepam in the back pocket ready for us to give to them if they're starting to experience some of that anxiety, maybe some agitation. So again, it's just things to be aware of.
Yeah, totally.
Yep.
Okay, so let's start talking about dosing and how we're going to prepare this specific to our agency here in Manitoba, and how we're going to give this to our patients.
Yeah, so when I'm preparing ketamine, I like to have all of my supplies out and ready. For this particular type of drug, I do want to dilute it. What we are carrying is going to be 100 milligrams in 2 mils. So I will take that and dilute it into 8 mils of saline in a 10 mil syringe for a final concentration of 10 milligrams per mil. And of course, I'm doing this alongside my partner. I'm having that medication double check with them. I'm using my medication formulary that has been provided by Westone. We have that medication formulary that we use, and I'm going to do my standard medical calculation for my dosage for this patient. And I'm always going to have my partner do the same calculation. Remember to always put a medication label on that ketamine as well when you are preparing it. Does anyone have anything else to add that they would
Yeah,
do when they're
can
prepping
I
it?
just add in there, Kat,
Yeah.
that when you get your partner to do the double check, just pass them the whole vial like we're supposed to do. But I know it's often we're going and someone's screaming at us. Just pass them the vial. It's always better to take that extra 30 seconds than to figure out down the road we made a mistake and then have to, one, undo that mistake with our patient or provide the supportive care they now need, or two, go down the road of re-educating and just going through this whole process because we just didn't take that extra 30 seconds. So just, I know some people get in the habit of, they get their medication drawn up, throw that into the sharps container, and then it's impossible for your partner to do that high alert double
Yeah.
check. So just
Just do it.
keep that out, pass it over. And if we do it every time, it becomes muscle memory, and then we'll get into that habit, or maintain that habit, hopefully.
Hmm.
Yeah.
And remembering we're not in a rush. Like, we can take that 30 seconds. It doesn't take long. Just take our time. 100%. I'm totally in agreement with the muscle memory. The more I do it, the more it just comes natural.
Exactly.
So one of the things we should touch on is the repeat of this dose, because that isn't something that we've talked about. So there is a repeat on it. If you guys were to bring up the care map right now, we can either give it a half dose in 10 minutes, or we can wait a full 30 minutes. So we kind of just want to clear that up for you guys. If you do the top up at 10 minutes, after you give that top up, you have to wait 30 minutes to dose again. But if you don't end up requiring the top up at 10 minutes, then you can redose at 30 minutes. So that's
Mhm.
just to kind of clean up that wording and get a good understanding of it.
Mhm.
Yeah, so you'll be waiting 40 minutes from the original dose if you give that top up of
Yeah.
2.5 mg per kg. And otherwise, you're waiting 30 minutes and you can repeat your original dose.
Yep, absolutely.
And we're talking about IM or IV for our ICPs, right? And then we also have available to us, if you're delivering this, if you're a PCP and you're going to give this med intranasally, do you want to talk about that a little bit? Maybe Lindsay, you want to hop on that and just talk us through how that process goes?
Absolutely. We can even bring up the care map when it comes to any of the dosing here, just to kind of refresh my memory here, just to make sure that I'm not guiding anybody in the incorrect direction here. When it comes to administering anything intranasal, we always want to make sure that we do not dilute it. So what you pull out of the syringe is the concentration that you're going to be introducing into the nares. Oh, awesome here. So
Sorry.
M17 is no, that's okay. So it's M17 is our ketamine care map here. So we're going to go down to the intranasal where it says primary work scope and above. So for our 12 months and older, it's 0.5 to 1 milligrams per kg, following with a 0.25 to 0.5 milligrams per kilogram after 10 minutes, again, if necessary, to achieve that adequate analgesia. So that's what we would call our top up dose. Okay. And then we would repeat with the 0.25, 2.5 milligrams per kg every 30 minutes as required to maintain that adequate analgesia. So a little bit earlier in this little discussion here, Kat did mention the word bioavailability. So again, just to kind of round it off, the dosage, the weight-based dose between the IV and the IM versus the intranasal is we just need more to go into their nose just because there is a smaller bioavailability for that drug to actually work. So we just need more drugs for us to get the exact same effect. So that's why you're going to see that different dosage there.
Yeah, and there is a dosing range in intranasal on that repeat. And
Yep.
so for our PCPs, for some of them, this might be a completely new drug. And using your clinical judgment when you are choosing those dosing ranges would be appropriate. Maybe you have Betty Ann, who is 90 years old. She may not require a full top up at 0.5, and she would be a better candidate for the 0.25 milligrams per kilogram. But then you might have Joe Blow, who is a big, strong young man who can have a bit more of a higher dose. We know our seniors are a bit more sensitive to our medication administrations. So thinking about those things when you're going to dose your patients would set yourself up for success.
Mm-hmm.
Yeah, and I think, again, just one thing to add in there, if our PCPs are using this for extended extrication times, but we can always still get that end tidal CO2 on, we can still put our monitoring on, and if you have to, just set your monitor on the hood of the car if that's what's going on, and you've got you can set it to the big screen so you can see it right there, the alarms start going off if something goes wrong. Because these are hectic scenes and there's a lot going on, it's easy for little things to get missed. So again, just go back to those basics and make sure you're adding in those tools we have available to us. We're so fortunate to have the X series monitors with all these capabilities, and we just need to make sure we're using them.
Yeah, and to round out and finish off this conversation about preparation, just remember, please don't infuse it. In our mini bags, keep it to that push dose, slow over 1 to 2 minutes. That's our recommendation. That's what's going to be safest. That's going to allow us to give precise amounts of drugs without the use of infusion pumps. We don't have those available to us not on all our trucks. So for now, it's status quo with push for IVs.
Yeah. Don't push it slow if you're giving it IM.
And don't dilute it if you're giving it IM either. We never talked about that. IM is as always, don't dilute that one either.
Yeah,
exactly. Always a friendly reminder.
Don't dilute it.
Yeah.
Okay. All right.
So have you guys? Yeah.
We've got that part covered. Yeah. Why don't you guys tell us a little bit about some experience you've had when we had ketamine available to us previously?
Go ahead, Kat. You're just about to kind of start a conversation.
Oh, yeah. So I've used it a few times, and I'm a really big fan of it. I've used it with the use of opioids as well, and actually in these particular patients also with the use of ketorolac as well. So I have had a middle-aged man who was involved in a traumatic incident, very large man, and he tolerated it very well. The scene, I did my due diligence. I told him he might have an out-of-body experience. I turned the lights down. We kept it nice and cool. I didn't overheat him. It was just a very calm environment. And at the end, he was very quiet and he was sitting there. He had no pain. And he goes, you're my angel.
Oh,
and I thought, oh, okay, that's the ketamine talking. But, I've done what I've set out to do is I've made my patient very comfortable. And just the surroundings, it was good. Ambient temperature. And very calming, and I was very quiet, and we didn't have the lights and sirens on. So I think that all kind of played a fact. And then the other one was actually a pediatric patient who it worked very well on a femur fracture, an open femur fracture. And, mom was there and we had that pain conversation and I explained everything to her and the different medications I was going to give, and she was okay with it. And he was quiet all the way to Brandon, didn't complain of any pain, and he was alert to my voice and his eyes would open. And I almost thought, oh gosh, like he's so quiet for the trauma that's happened, but that's the medication, that's what it does. So it was very successful for sure. What about you, Lindsay? I know you've given it a couple times.
So literally everything you said is exactly my experience, but I will props a lot of that success again just to purely setting up the patient for that experience. So obviously it's a very, very stressful situation when we're in these very traumatic scenarios here, but really again, get the patient into the vehicle the best that you can, or try and reduce all that external stimulation the best that you can. So shut the music down, nothing too scary, shut the lights down. And again, it's just talking to your patients and try and make that explanation of the medication relatable to the patient. So exactly like what Kat said earlier, we need to be talking in a way that our patients are going to actually understand, especially when it comes to something like this. So yeah, literally the experience that you just explained with that gentleman as well as that child, that's exactly what my experience is. And again, it was very successful when it came to actually treating their pain and getting them to the facility safe and comfortable.
Yeah, the only thing, slightly different experience that I had, and at some point when these calls blend together, I'm not sure if it's a call I had or I just heard about, but either way, someone was given ketamine and it was for an arm injury, and they said, oh, I feel like my arm's floating, and there was no pain. So anyways, I think it's such a useful option for us. Not everyone's getting it, but it's an awesome tool in our toolbox. And I think we should all be excited to have it back.
Absolutely.
Okay. Yeah, we're excited. Lindsay, Kat, and I are excited that
Yeah.
we tried something new here. If you were just listening along, hopefully you found this useful. If you did, let one of us know. If
Mm.
you didn't, let one of us know. And we want feedback, good or bad. If this was beneficial for you, let us know. But do you guys have anything you want to add in here before we shut it down?
No, honestly, I think it was really good discussion. Maybe just for the listeners who are kind of listening to this is like a podcast, maybe we should just say our phone numbers just in case they're like, oh, I have a
Yeah,
really good
sounds
question
good.
or really good experience. So, I'm Lindsay Dudich. My work phone number is 204-914-0806.
And final words from me are, if you guys want any further literature, please reach out to either one of us. We have the
Hmm.
sources
Yep.
from our research that we would be happy to pass along to you guys to aid in your learning. There's also a 2-minute neuroscience video on YouTube that explains and has a visual of how ketamine works on the receptors. So if you guys want that, please reach out, and you can get a hold of me at 204-759-4524.
Hmm.
Awesome. And yeah, my name again is Joel Yannick. I'm training officer here in Brandon. If you want to give me a call, it's 204-729-2497, or send me an email. It's j.yannick@brandon.ca. So yeah, if nothing else, ladies, then thank you so much for your insight, and hope everyone has a great day and stay safe on the streets.
Yeah, thanks for the collaboration. This was fun.